Good evening, friends. It's a pleasure to be a part of the scientific program of SAGES. I would have preferred to be there in person, but the situation demanded otherwise. So today I am going to talk in favor of a topic saying revisional surgeries are not desirable in most weight regain patients. I bring greetings from the beautiful city of Mumbai in India. I have no disclosure to make about my company affiliations. This is my case mix. As you can see, we do primarily Roux-en-Y gastric bypass, and a very small proportion of our practices are revisional surgeries. So what is weight regain? Weight regains are defined in various ways, and it has been seen to occur in almost 70 to 80% of patients after 5 years, and to the tune of up to 15% of total weight lost. Revisional surgeries have been reported to be around 9% worldwide in 2018, and which is a substantial number. As far as outcomes are concerned, it has been seen that revisional surgeries lead to excess weight loss of almost 65 to 68% and total weight loss of 16 to 23%. So the question comes, if the weight loss is so good, why do we question their legitimacy? So there are various reasons. Let's look at the literature. When we look at weight regain, this is an Indian study of about 9,000 patients, where weight regain at 5 years was reported as 14.1% of lost weight, or almost 2 BMI points, but in actual terms, the weight regain was 5 kgs. So when you look at numbers, they may show you otherwise, but actual weight gain may be limited. Now, it has also been seen by this study by Dr. Rubino's group, which has shown that even after 10 years in weight regain patients also, comorbidity relapse is not a major problem. And then the issue of weight re-regain after revisional surgery. So this particular study has shown that almost 27% of revisional Roux-en-Y gastric bypass have regained their lost weight. And this is important because we need to see the long-term outcomes of revisional surgeries to see their efficacy. And then one of the major issues that remain unanswered are etiological factors of weight regain. So this particular study has shown that their relative contribution of diet is almost 25%. Relative contribution of lack of physical activity is 21%. And motivational issues are almost 20% in weight regain. So when these are the issues, doing a revisional surgery in presence of these issues is obviously questionable. Individually looking at them, the post-operative diet, there are multiple studies to show that higher in food indiscretions are seen in weight regain patients in terms of excessive calories, snacks, sweets, oils, and fatty foods. Eating behavior-wise, it has been seen that weight regain is seen much higher in grazers versus non-grazers, almost between difference of 70% to 12%. And then the role of follow-up with the bariatric program. It has been seen that the patients who are regaining weight have done less follow-up as compared to those who maintain their weight in long term. And then a so important role of physical activity. There are multiple studies to show, but this particular study has shown that there is significantly less post-operative physical exercise in weight regain patients compared to those who are maintaining. And this leads to altered body composition. So patients who have weight regain had less fat-free mass, and that lead to decreased resting energy expenditure. Besides these things, the psychological aspect of the person is so important. It has been seen that people with psychiatric disease, almost 30% of them regain weight within 1 year. And post-operative depression independently is a determinant of loss of eating control and weight regain. And not only these, the metabolic benefit that happens after a surgery probably reverses, and there are multiple studies, as I say, The first study shows that at 2 years after a Roux-en-Y gastric bypass in weight regain patients, higher ghrelin levels are seen. There is a failure to sustain elevated PYY level, and there are lower GIP and GLP-1 levels after meals in these weight regain patients. If you look primarily at technical causes which causes weight regain in bariatric patients, so remnant antrum in sleeve gastrectomy patients is probably the only factor which has been shown to cause the weight regain. So if the remnant antrum is about 2 centimeter size, then weight regain is seen in about 4% patients, but if it is 6 centimeter size, it is seen in about 22% patients. The usually perceived dilatation of sleeve is really not a big issue, because as has been seen in the first study, even double the size of sleeve at 2 years did not cause any weight regain, and when it became 4 times, it did not cause much except about 15% weight regain. As far as Roux-en-Y gastric bypass, the only factor that has been blamed is the stomach dilatation. So in weight regain patients after gastric bypass, almost 60% patients have stomach dilatation, and it has been considered the only anatomic variant responsible for weight regain in Roux-en-Y gastric bypass. When we go on to the literature, there are very few studies which have mentioned that patients before revisional surgery were put on a lifestyle attempts, and those studies which mentioned the lifestyle attempt did not mention their outcomes. How many patients the surgery could be avoided because they could lose weight with diet and exercise or medicine? So let's look at the treatment part. Dietary intervention in weight regain is seen that if patients are put, by this study, it's a RCT, patients are put on whey protein supplement, then they have lost about 2 kg weight and maintain their fat-free mass. Now, 2 kg may look less to you at the moment, but if you look at the numbers in terms of percentage excess weight loss, it may be substantial. As far as medicines are concerned, now since we have better and better medicines coming forward, if you look at various studies, they have shown between 54% weight loss in patients who have lost more than 5% weight loss. Another 30% patients have lost more than 10% weight, and another 15% have lost more than 15% of total body weight, and likewise. So these are almost at par with what we can achieve with revisional surgeries. Then as far as complications of surgery are concerned, this is our own study which we did, where we compiled data from about 12,000 patients, and where we have shown that the revisional surgeries have almost 12% complication rate compared to 3% with the primary surgery. But the complications are different. The complications are more related to bile reflux, nutritional deficiency, GERD, obstructions. The complications are not significantly different in terms of bleed, leak, DVT. So these are procedure-related complications and not necessarily technique-related complications. So friends, primary and revisional surgeries are not alike. Most of the revisional surgeries involve longer BP limb and shorter common channel. So we need to realize that what is good for goose, that is what is good for primary surgery, has to be good for gander as well, and revisional surgeries have to be modified accordingly. So it's time to bring back science in revisional surgery. We need to have definitions of weight regain. We need to have contributing factors management built in an algorithm. We need to have documented conservative attempts as we have in primary bariatric surgery before we attempt a revisional surgery. We need to have consideration of procedure complications. How, if we cannot offer a patient a short common channel as primary procedure, how can we offer it as a secondary or a revisional procedure? We need to see the long-term weight maintenance related to revisional bariatric surgery. And we must have a revisional surgical guidelines like cutoff BMIs, whether we should do it only for weight regain or whether we should do it only when it's having a health impact on the patients. So friends, to conclude, I would like to say revisional surgeries in my mind is an ethical challenge. I also do revisional surgeries, but it's a challenge. It's not a question of whether they are required. The question is whether they are desirable. We are doing a revisional surgery multi-centric trial, and we have about 150 surgeons from 45 countries participating. I invite you all to join it to produce data which is missing. And this data audit you can join it in this study even now. Thank you so much for the SAGES organizers and scientific committee to involve me in this program. I would be very happy to join you maybe next year in person and to meet you in person. Thank you so much.